Good evening, folks. Dr. David Rawson, president and founder of this academy. This is webinar number 27. Tonight, we're very pleased and excited to have Dr. Michelle Cantwell, a dentist in the States, who is a graduate of the Wilkes University located in her hometown of Wilkes-Barre, Pennsylvania. She attended the University of Pittsburgh School of Dental Medicine and graduated in 1998. Upon graduation, she completed a 3-year residency in prosthodontics at the University of Pittsburgh School of Dental Medicine. She received a U.S. Navy scholarship and served at Sewell's Point Dental Clinic, Naval Dental Center in Norfolk, Virginia. She completed her active duty service as a lieutenant commander in 2004. You'll know that we pronounce it lieutenant in Canada. I got to be a captain only, so honors to you. Dr. Cantwell opened the Cantwell Dental Group located in Lancaster, Pennsylvania in 2005. As her prosthodontic practice grew, she found it was becoming increasingly important to devote specific time and resources to the sleep medicine portion of her practice. A number of years later, in 2012, she opened the Center for Dental Sleep Medicine in Lancaster to create a practice devoted solely to the needs of her sleep medicine patients. She and her team are committed to staying informed of the latest updates in dental sleep medicine. She is one of 230 dentists who have completed their board exam through the ABDSM. She remains actively involved in the American Academy of Dental Sleep Medicine, as is currently serving as the chairman of the Education Committee. Dr. Cantwell, it is indeed a distinct pleasure to welcome you virtually to the wonderful, friendly country of Canada. Please take over.
Thank you so much for the warm welcome, and I am absolutely thrilled to be a part of tonight. I'm happy to say that in the years that have passed, I'm now actually on the board of directors of the AADSM, and my practice went from private practice to being merged with the hospital system. So every day I am humbled to learn new things. And I'm so excited to be with people that want to learn new things as well. And I hope that there's something in the talk tonight that will spark some interest in maybe looking at your patients in a different light. So with that, I am very excited to share a topic that's near and dear to my heart, gender bias in sleep medicine. Now, obviously, with the time constraints, this is going to be just a very cursory look at things. But again, my hope is that this takes us from practicing in a one-size-fits-all type of mentality into more of a precision medicine. And bear with me one moment here. There we go. Didn't see my cursor. There we go. So just listing some of the topics that we're going to touch upon today, it's really going to be just a very general look at what to expect when considering the chief complaints in women, differences in sleep studies, clinical statistics, and just an overview of what to expect also with your pregnant population in your practice. And with that, let's move straight ahead. So what really got us started looking at this was back in 2019, the NIH decided to make a strategic plan that focused on women's health. And with that, the years leading up from there, we saw a marked increase in the number of publications that dealt with gender-related issues in testing, screening, outcomes of treatment. And this is all very new and very exciting, but the focus on gender differences isn't really a new thing in sleep. We know that obstructive sleep apnea has essentially been a pandemic. The authors of and I should mention too, any of the slides that I share with you, just in case you want to take a deeper look at things, the citation will be down at the bottom of the slide for you. The authors of this 2020 publication noted that the worldwide prevalence was estimated at close to 1 billion people. And it begs the question, if OSA is so prevalent globally, why are so many people undiagnosed? And are the current diagnostic criteria based on the simple metric of an apnea-hypopnea index greater than 5? Is it sensitive and specific? And to further complicate that, is the criteria missing women or perhaps overdiagnosing men? And the authors, they summarized that the current diagnostic criteria, it just lacks sensitivity in determining OSA in women. So how do we, as practitioners, always looking for a new and better way to treat our patients, how can we approach this as targeted precision medicine? And not surprisingly, the answer to this is just complicated. It just is. It's when it comes to unpacking the impact of gender and sleep medicine, it's just not black and white. So I always think to understand a present condition, it's very helpful to understand a little bit of the history and the background. So I think everyone has probably seen this gentleman here. It's the Pickwickian image from Dickens. And you'll see him again and again in a lot of the sleep lectures that are given. Dickens described him 140 years ago, before we even understood what sleep apnea was. But if you look back in the Pickwick papers, he perfectly describes what sleep apnea would appear to be to an observer. So historically, before we even understood that sleep disordered breathing had gender and genetic phenotypes at play, obstructive sleep apnea was considered predominantly to be a male disease. And although the Pickwickian image is 140 years old, we still recognize it in, common TV shows today. It's still the stereotype that gets the attention. And I'm not trying to downplay that, obesity and class 2 malocclusion have a strong connection with obstructive sleep apnea. But, there's also good reasons why women aren't considered as having a high incidence of obstructive sleep apnea. Women weren't even included in the earliest epidemiological studies. So in the early days of sleep medicine, it was thought that the ratio of men to women were anywhere from 60 men to 1 woman. And we know clearly that that's not correct. We have a better understanding of the prevalence rates today. And that's due in no small part to the work of a very important researcher by the name of Dr. Terry Young. Dr. Young's work created a paradigm shift. She led her team to generate an article which still continues to be one of the New England Journal of Medicine's top 10 cited papers for the last 2 decades. Her research is based on overnight in-lab studies and other protocols conducted every 4 years on a large population-based cohort of men and women, and it's known as the Wisconsin Sleep Cohort. It was published in 1993, and I want you to remember that date, put that in your pocket, because we're going to circle back to that in a little bit. So Dr. Young's team identified that OSA is indeed occurring in women, but why weren't they being identified, tested, and diagnosed earlier? And that's the real question that we want to tease out. We know that there was a disconnect between patient and provider, and Dr. Young's team suggested that maybe the predictors and the chief complaints just aren't the same for men and women. At one point, Dr. Young noted that regardless of severity, women weren't reporting symptoms that differed significantly from those of men, but she did accept that perhaps there was a disparity in their typical symptoms. And clearly, she understood there was a lot more research to be done. Dr. Young in 1993 suggested that the reasons for gender disparity in sleep apnea diagnosis, including the possibility that healthcare providers disregard typical symptoms and chief complaints in women. And what were the chief complaints? Well, men tend to present with the classical chief complaints. I'm snoring. I'm so tired during the day. I'm nodding off in meetings. But women don't tend to describe extreme exhaustion or falling asleep in a meeting. It tends to be more of a general fatigue that they attribute to other causes. And they are also more likely to describe morning headaches and insomnia. Now let's take a look at this 2018 article. And I really love military research for a lot of reasons. Basically, they can control for variables that you can't control for in the general population. You don't seem to see the same attrition rates. And when it's time to retest, they can basically order their patients to come back. So this publication, they found that nearly 50% of the active duty females presenting for a sleep study, diagnostic sleep study, had obstructive sleep apnea while not manifesting any of the typical signs of obesity or increased age. And think about it, it's military. You know, you have to be within a certain age range, you have to be within a certain BMI. And so this article I found to be particularly interesting. So in addition to not presenting with the typical look of one who has OSA, the active duty service women had notable behavioral medicine and pain disorder complaints. And this is what they presented with. The top complaint was not fatigue, was not snoring, was not any of the signs that you or I might think of in our private practice. They complained about pain, anxiety, depression, PTSD. Think about how many patients you have in your practice that are on anti-anxiety medicines, antidepressants. It begs the question, you know, should we be looking at them and screening them earlier? So as the years passed from Dr. Young's original paper, there were many, many, many more studies that supported her concept. This particular study was Dr. Christine Lin back in 2008, and she found even back then that women with sleep disordered breathing were often misdiagnosed with depression or other illnesses before they ever received a sleep study. So are there gender-related differences in comorbidities among patients with obstructive sleep apnea? And I hope you can forgive me. I'm going to jump around a little bit because I want to cover a lot of material in the time that we have together. So yes, this particular paper in 2015 found that there were differences, and they're listed there for your convenience. Now, let's jump into some of the screening tools that we commonly use. And given time constraints, let's just focus on the two that I think are probably the most popular or the most commonly used, I should say, the Epworth and the stop bang. So women across the board tend to score lower on the Epworth sleepiness scale. They were actually 38% less likely to have an abnormal screening response. So I share that with you in the hopes that when you are screening your patients, ask open-ended questions and don't let normal ESS score be the end of the conversation. Because the Epworth just doesn't accurately represent women. If you rely solely on it, you're going to detect only about 1/3 of the women who desperately need your help. The first screening tool, this is the first screening tool I would say most of us receive, and women just tend to score lower on it. And it just makes me wonder why. Now, I can't really tell you exactly why that would be, but I can tell you that this score, the ESS, was designed by Dr. Murray Johns in 1991. And this screening tool that most of us use was written before the Wisconsin Sleep Cohort, the first population study, we talked about this, the first population study that even included women was even published. That was published in 93. So this was written when medicine in general just didn't believe women experience OSA at the same rate that we now understand to be true. Now let's take a look at the stop bang. This was written by Dr. Chung, and it was written by anesthesia, for patients in a surgical setting. But I think you'll agree, many of us use this in an ambulatory setting, even in private practice, but is it really appropriate for every patient in our practice? So let's try an example. Would you expect the stop bang to help properly screen a young pregnant woman? So let's take a closer look. So we have a 27-year-old female. She's working a 7 a.m. to 3 p.m. shift at a hospital. Nothing really remarkable about neck circumference, body mass index. She's young. In the surgical population, a high stop bang score means a high probability of moderate to severe OSA, and that high score would be a 5 to an 8. So the highest a pregnant woman would be able to possibly score would be a 6. And if she doesn't sleep the same hours or in the same room as her partner, or if she doesn't have a partner, the highest she's going to score is a 4. And that's assuming she does have high blood pressure. So you can see very clearly that not every screening tool is necessarily going to work for every patient. But let's shift gears now. How about a PSG? Well, women tend to have lower apnea-hypopnea indices, longer latency to REM, and female-specific symptoms on the PSG. This particular researcher found twice as many men as women receive a PSG, and the referrals of the men were often initiated for medical exam because of abnormal observations by their bed partner. This study was very interesting. It looks at 2,000, just over 2,000 participants, and they all underwent a PSG. And the authors found that the definitions that use a 4% desaturation criteria just really underestimate the apnea-hypopnea index in women. And they also found there to be significant sex differences in the non-REM AHI levels and in physiological endotypes. I apologize here. My screen does not want to move. There we go. Now, in this study, they found that there were also differences in clinical features. Men and women both tended to report nocturnal choking, morning headaches, fatigue, insomnia, impaired memory, mood disturbance, reflux, but men reported witnessed apneas more frequently. Women had decreased total sleep time and sleep efficiency and increased sleep latency as compared to the men in the study. And what did the researchers conclude? They found that the data suggests the frequency and severity of sleep apnea is lower in women with OSA, and they present with female-specific symptoms and increased medical comorbidities. And publication after publication is repeating these differences between the genders. This particular study looked at over 2,800 patients, and they found that women presenting for diagnosis of suspected obstructive sleep apnea, they have more medical comorbidities at the time of diagnosis. So it begs the question, what do you think about that? Could it be that the increased comorbidities are present because women go undiagnosed until some other medical condition drives them to their doctor's office? It's an interesting question. Now let's take a look at gender differences in oral appliance therapy specifically. This is a 2018 paper, and it compared oral appliance efficacy in men and women with obstructive sleep apnea. And the researchers looked at a total of just over 500 OSA patients. And they found that twice as many women had class 2 malocclusion. And I'm sure this comes as no surprise to those of you, seeing this in your own practice. because greater overbite has been described as a predictor of OSA and as treatment success, predisposing patients with class 2 division 2 malocclusions to a higher success rate. And were there gender differences in response to oral appliance therapy? Some, yes, there were some. Oral appliance therapy was effective in women with obstructive sleep apnea of any severity, with significantly higher response rates as compared to men, especially in the higher AHI level. Keep in mind when reviewing some of these articles, though, it gets confusing. There's gray areas because many of the authors select different benchmarks of success. In this particular study, they looked at a 50% drop in apnea-hypopnea index. The authors here also found that there were, excuse me, the authors also found that there were sex differences in the occurrence of side effects. Women, if they experienced temporomandibular joint issues that were not addressed quickly, they were much, much more likely to drop out of treatment. So remember that, just something to consider for your practices, follow-up protocols, that if you have a woman that is complaining of facial pain, TMJ issues, the sooner that you can get to her and address that, the more likely for treatment adherence. So just to summarize this last part, women in general tend to experience less severe obstructive sleep apnea than men, a lower AHI with shorter apneas and hypopneas. So let's remember a couple slides back when we were discussing Young's 1993 publication. It was noted that regardless of severity, women weren't reporting symptoms that differed significantly from those of men. As the team spent more time, collected more data, and had the opportunity to let the work evolve, they saw differences emerge. Women with lower apnea-hypopnea indices were the ones going unrecognized, specifically women with an AHI under 20. And that disparity still exists now. Excuse me. Epidemiologists found that the ratio of 2-to-1 or 3-to-1 was logical to expect, but clinically, what do we see? Well, in the clinical settings, that ratio becomes 8 men being seen for every 1 woman. So even though we have the data and we understand that there are disparities there, women are still going unscreened, untreated. So let's switch gears again. Let's look at pregnancy and obstructive sleep apnea. And this next section is a very, very brief introduction, and it's just meant to get you asking questions. And hopefully you'll want to explore this. It is a very challenging component of medicine because pregnant women are difficult to treat. They change so quickly. And it's kind of logical to think that women would be at risk to experience obstructive sleep apnea, given all the changes that their body goes through. One of the things that I want you to take home with you, though, and to remember is that even snoring is significant in the pregnant population. It's been linked to a higher incidence of C-section and delivery of babies who are born small for gestational age. So snoring in pregnancy should never be ignored. There's an increased hazard ratio for delivery among frequent loud snorers. This particular study compared women who snore with control patients, and it was adjusted for pre-pregnancy, pregnancy, and delivery characteristics. Patients were all non-hypertensive, non-diabetic women. And it gathered prevalence rates from 33 studies. So the authors of this meta-analysis estimated that the worldwide prevalence rate of obstructive sleep apnea during pregnancy is about 15%. But these values vary significantly based on many factors. And as you look at different studies, you're going to see it is very hard to compare because women are often tested differently and at different times in pregnancy. So this next study was the single largest prospective study, and it involved 3,300 women at 8 clinical sites across the United States. These women all underwent home sleep apnea tests in early pregnancy, estimated between 6 to 15 weeks of gestation, very early. And again, in mid-pregnancy, between 22 to 31 weeks of gestation. In this particular study, they found the prevalence rate was 3.6% in early pregnancy, rising to 8.3% in mid-pregnancy. And other observational studies have been conducted, and it really varies. They've shown a prevalence rate anywhere from 17 to 45% of women experiencing sleep disordered breathing by their 3rd trimester. And of course, you're probably wondering, well, why are the numbers so different? And what I want you to think about is the stage of pregnancy they were tested at. And very importantly too, PSGs are so much more accurate than the home sleep apnea tests used in some of the studies. So you're going to see the numbers vary just based on the type of test alone. But why is sleep disordered breathing still so underdiagnosed in pregnancy? And that is really the million-dollar question. Essentially, providers and patients, they just expect disrupted sleep at this point. When a woman's pregnant, she's not going to sleep well. It's just expected. Sleep disruption, fragmented sleep, daytime hypersomnolence, they're all typically attributed to factors including weight gain. And is obstructive sleep apnea in pregnancy all about weight gain? All I can tell you is, as a woman, be very careful before you ask any women this question. It's the type of thinking that could get you really hurt. Obstructive sleep apnea in pregnancy is so much more than weight gain. It's multiple factors, although certainly weight gain plays a role, not to be discounted, but you've also got to factor in fluid retention, nasal congestion, increase in neck circumference, increase in blood volume, and pharyngeal edema. They all play a role. The incidence of insomnia and incidence of restless leg syndrome, these also increase during pregnancy and contribute to the fragmented sleep. So there's physiological changes in pregnancy that predispose patients to obstructive sleep apnea. The role of airway narrowing in OSA has not been studied in pregnancy, but we know that there's a significant link. And the internal size of the airway in the general population and in pregnancy, it's different. It changes. During pregnancy, the oropharyngeal diameter appears to narrow, and even the Mallampati grade tends to increase. So if we know that physiological changes are going to lean towards developing obstructive sleep apnea, then why is OSA during pregnancy still underdiagnosed and very rarely treated? In part, it's because these conditions change so rapidly, and because the patient's sleep pattern is already disrupted. Heartburn, nocturia, hormonal changes, muscle pain, fetal movements, these are all going to just make the sleep pattern very disrupted. Nasal patency is also different in pregnancy, and it's thought that the changes in the nasal mucosa are due to increased blood flow and variations in the circulating levels of both estrogen and progesterone. During pregnancy, nasal patency is impacted by blood volume. One can expect a 50% increase in blood volume with an average pregnancy, and 60% or higher with twins, and with multiples, it just continues. So, not surprisingly, there's other studies that have noted that advanced maternal age, increased body mass index were risk factors for 3rd trimester sleep apnea among women who didn't have any signs of sleep disordered breathing prior to their pregnancy. This study that I'm showing here This looked at 105, I think, 110, 105 pregnant women from the University of Pennsylvania. And they completed first and third trimester overnight PSGs. And what they found is that severe complications can result from untreated OSA during pregnancy, with a 2.5 to 3.5 times increase in cardiomyopathy, congestive heart failure, and incidence of hysterectomy. And there was also an increased risk of very, very serious other comorbidities, as well as great risk to the baby. The authors of the study found that there was an increased risk of preterm birth and greater likelihood of admission to the neonatal intensive care units for babies born to mothers with untreated sleep apnea. Now, this paper, this was a 2017 paper entitled "Obstructive Sleep Apnea in Pregnancy is Associated with Adverse Maternal Outcomes, a National Cohort." And these researchers, they looked through the medical records of over 1.5 million pregnant women in the US between 2010 to 2014. And what did they find? Well, they found that women with obstructive sleep apnea had hospital stays and admission to the ICU at a much higher rate. How much higher? They found that the risk of ICU admission was 174% higher in pregnant women with OSA versus those without OSA. And the length of hospital stay also increased. Compared to pregnant women without OSA, the pregnant women with OSA in our national cohort had a higher risk, significantly higher risk of pregnancy-specific complications such as gestational hypertension, gestational diabetes, cardiomyopathy, pulmonary edema, congestive heart failure, and hysterectomy. OSA diagnosis was also associated with a much longer hospital stay. And on that previous slide, you saw 5 days listed. Theirs raised up to 5 days, the average. And as we said before, significantly increased risk of admission to the intensive care unit. Now, just to drive the point home, I mentioned these comorbidities, but let's look at the percentages that this cohort found. Hysterectomy was 126% greater. Cardiomyopathy, 259% greater risk. Congestive heart failure, 263% higher risk. Pulmonary edema, 406% greater risk, all just because of a diagnosis with untreated sleep apnea. Now, moving on, looking at this study, they found that even untreated mild, just in case you're thinking, well, these are all patients that are very, very severe, mild patients, really not as much of an issue. Even untreated mild obstructive sleep apnea in the mother was linked to changes in fetal development. And remember, we said snoring was important. So what about just women that snored during pregnancy? Turns out that just snoring alone was enough to increase the odds of unplanned C-sections. This study was led by a researcher by the name of Michelle Oken, and she looked at over 400 women in their third trimester. And they found that just chronic snoring in this population was enough to increase the odds of an unplanned C-section, with all the possibility for risk that that surgery brings. And if the mom had insomnia or snoring, the baby was more likely to be born large for gestational age. And the combination of these changes, it's just remarkable, and it's going to impact women throughout their life. So let's switch gears again and now take a short look at the changes that occur following menopause. So obviously, obstructive sleep apnea rates are higher in men at different ages versus women. As women age, we experience a higher level, and it's thought that the higher levels of estrogen and progesterone protect women prior to the onset of menopause. The hormones are responsible for maintaining the airway's muscle tone and keep it from collapsing. And as these levels drop during perimenopause and then drop again to their lowest levels as part of menopause, the incidence of sleep apnea in women is going to increase. And this occurs in both natural and surgically induced menopause at any age. They were both associated with a higher risk of developing obstructive sleep apnea. And this is another thing that I thought was interesting. I thought it's a little bit apart from the rest of the presentation, but I wanted to share it with you. I'm not sure how prevalent the placement of hypoglossal nerve stimulation or Inspire is currently, but for those of you familiar with it and referring for it, one of the things that they do to determine if a patient is an appropriate candidate is to do an endoscopy and see what the pattern of collapse is. If it's an anterior posterior collapse, it's favorable for the placement of Inspire, and the patient should have good outcomes. If it's a concentric collapse where everything is kind of collapsing in on itself, those patients don't respond as well to Inspire. And I thought this was interesting that the pattern of collapse in women is different following menopause. Postmenopausal women tend to have more of a concentric collapse. Now, I haven't read any articles or seen anything posted just yet that explain whether or not Inspire is affected by that, but I thought it was interesting, so I thought I'd share that with you. So this is just a quick summary of what I hope to bring to the table tonight. Just remember, women are going to have different chief complaints than the men in your practice. That a diagnosis of anxiety, depression, insomnia, they may actually be something that you want to dig a little bit deeper and see if perhaps there is need for screening for obstructive sleep apnea in that patient. And, just remember that there's going to be changes throughout a woman's life. She may not have obstructive sleep apnea at one stage. She may develop it, resolve it. It's just something that you can't have too many conversations with female patients in your practice to really make sure that we're addressing their issues. And with that, I want to thank you for inviting me tonight and for being so kind. I do appreciate your attention.